Before I really begin, I want to make an acknowledgement. I appreciate that this is a long slide and not all of you will be coming to us from Canada or be watching from Canada, but I do want us to recognize that we live, work, and play and participate in a community on the unceded, ceded, and traditional territories of, in Canada, 203 First Nations, along with 38 Métis chartered communications. Each of us possess our own unique traditions and history here on this land. That we now, at least here in Canada and where I am, refer to as British Columbia. I want to acknowledge the importance of the Truth and Reconciliation Commission of Canada's call to action, the United Nations Declaration of Rights of Indigenous Peoples, and the BC Declaration of Rights of Indigenous Peoples Act. And I wanted to urge you, I was trying to figure out where to put it, and no matter where you live, whether or not you're in Canada or not, to seek out what the Indigenous culture is in your in the territories that you live in. In all of our work, we're committed to ensuring Indigenous women's rights to health and safety and an equal opportunity to participate in a manner that recognizes and respects Indigenous cultures and traditions. Today, I myself am joining you from Vancouver, which is part of the unceded homelands of the Coast Salish peoples and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I want to also acknowledge that we have a number of sponsors without which we couldn't hold this series. It was supposed to be in Vancouver in person in May 2020, but of course we divided it up into several of these different symposia. Our sponsors are listed there, particularly CIHR, Michael Smith Foundation, Elsevier, Elizabeth Ryda, who gave us a donation from her sex and gender chair. If you wish to engage, please tag us on Twitter with the so Women's Brain Health Conference 2021 hashtag, if you so desire. I wanted to also say that there is, particularly for you trainees out there, there's a trainee mentor session on March 2nd next week. I think that's Tuesday from 10 to 11 a.m. PST. And this is Robert Paul Juster, who's at the University of Montreal, who will be talking about stress and resilience. But he has a lot of intersectional and transdisciplinary approaches to the work that he does, particularly with respect to LGBTQI2S individuals. So he has some really best practices. He has a Meet the Methods coming out for CIHR on specifically LGBTQI2S issues in research. And with that, I urge you to join us if you're not already a member, and tag us on Twitter as we go along. And without further ado, I'm going to introduce Dr. Angela Cullen Antiano. I'm sure I didn't say that right. And you can start sharing your screen while I read her bio. She's a professor at the Department of Occupational Science and Occupational Therapy and Rehabilitation Sciences Institute in the Metri Faculty of Medicine, University of Toronto. She currently holds a Tier 1 CRC, that's a Canada Research Chair in Traumatic Brain Injury in Underserved Populations. She's a Fellow of the Canadian Academy of Health Sciences, the American Congress of Rehabilitation Medicine, and the American College of Epidemiology, and we're really happy and privileged to have her here speak. I always ask for fun facts so that behind the accolades, you know that there is a person who enjoys things other than science. Not that we don't enjoy science altogether, but her fun fact is that she enjoys wilderness canoe camping in Algonquin Park, which is a beautiful park if you haven't had a chance to see it in Ontario. So without further ado, Angela, thank you very much.
Thank you very much for that introduction. And I'm just going to stop my video because of my bandwidth issues. So I wish to thank the organizers of the Women's Brain Health Cluster at UBC and Paul Van Donkelaar for the invitation to speak at this, the conference Symposium on Traumatic Brain Injury, to talk about this really pressing public health problem that affects persons across ages, sexes, genders, and people across the globe. And I'm pleased to share what I've learned about women and traumatic brain injury from a life course perspective, a historically very under-researched area. I also recognize my own positionality with respect to this talk as a cisgendered, heterosexual white woman of privilege, and my pronouns are she, her. In terms of
Oh no, your audio is cutting in and out. Can you hear me, Angela?
I can hear you, but I cannot advance the slide. I'm not
Oh,
sure why.
uh, maybe just click on it again and then it should advance on your screen.
It's totally stuck.
The fun of Zoom.
Okay.
You could stop sharing and try it again, I guess. I would just click
Okay.
there. You're on there right now. Just click on it and then try to do page down. Oh,
Oh,
this
screen.
will work too.
Okay, it's not advancing.
Ah, there you go.
Okay. So I'm sorry about that. In terms of a background in my research, I hold a Canada Research Chair in the area of traumatic brain injury in underserved populations, which builds upon decades of research in this area. And our research program has examined traumatic brain injury among populations, such as persons who are homeless, vulnerably housed, persons involved in the justice system, persons who obtain their brain injury through violence with a focus on intimate partner violence, high-risk workers, older adults, and Indigenous populations. And our research also aims to integrate sex and gender considerations throughout the research, and we've had a specified focus on female, women, brain injury. And we also work in collaboration with stakeholders, users in our research, and aim to co-create knowledge. Much of our work is also directly led by many of our outstanding trainees. So I held a CIHR research chair in gender work and health, focused on brain injury, so that we have been trying to address inequities in research focused on women with brain injury. And our lab led what we believe to be the first international workshop on women with traumatic brain injury in collaboration with a broad range of stakeholders. And this was an agenda setting workshop, supported by persons with lived experience, brain injury service providers, researchers, funders, and advocates. And through this, we identified some key priority areas for research, such as violence and abuse, aging, psychological and emotional health, girls and adolescents, community integration, and reproductive and sexual health. And these are topics which we will be discussing today. And in this workshop, women reported dissatisfaction with their care, their gendered experiences, not being believed. And this continues today in the research that we are currently conducted. And I have to say that the greatest support for women for this research has been from women with lived experience of brain injury, which is incredibly validating to do this research that end users want. Well, I speak about the importance of integrating sex and gender in traumatic brain injury and other relevant research. I wish to acknowledge the importance of an intersectional approach that considers factors that could help us better understand sex and gender influences in our research, as well as the heterogeneity that there is in the research findings. And in many ways, to title this invited review from our lab, Traumatic Brain Injury, Sex, Gender, and Intersecting Vulnerabilities, led by Tatiana Molieva in our lab, sums much of our research program. And in this review, the model is presented to assist in better understanding our study results that considers important determinants of health, such as age, education, occupation, race, and ethnicity. And it's important to consider these factors in interpreting our results on sex and gender. I thought I would start by giving an overview of traumatic brain injury, as I'm not sure to what extent the audience is familiar with this area. Traumatic brain injury has been defined as an alteration in brain function or other evidence of brain pathology caused by an external force. It's a major cause of death and disability globally. And major causes of injury are falls, motor vehicle collisions, being struck by an object or a person. And it's a complex condition that can have cognitive, physical, and emotional sequelae affecting function and community integration long term. It's also an invisible disability, and there's a lot of heterogeneity in presentation. So this is by no means exhaustive, but some major consequences of traumatic brain injury include problems with cognition, such as problems with memory, judgment, communication, concentration, Physical challenges include headaches, problems with balance, strength, coordination. Special senses can be affected, sensitivities to noise, light, fatigue. Emotional, psychological sequelae can include emotional instability, impulsivity, and depression, and it can also affect sleep. And there are mixed results regarding the clinical symptoms and recovery by sex and gender. However, it has been found, numerous studies have found, and reviews have found that more symptom load and longer recovery time among among girls and women with mild and moderate injury. But we do need more data to inform evidence-based guidelines and clinician education. In terms of incidence by sex across the lifespan, I'm drawing upon the work from this global burden of disease study published in The Lancet, and I understand the Women's Brain Health Cluster is international, so I'm presenting international rates. So global estimates vary by sex, and this is a graph from that report. And overall, you can see the incidence rates by sex are more similar in the early and later stages in life for both levels of severity. And typically the overall incidence is higher for males, which is highest in youth and early adulthood, particularly in the moderate and severe injuries. And this has been cited as a reason why there's been less emphasis on studying women or sex differences. When there is data that captures less severe injuries, such as concussion, you tend to see more females included in the sample and less divergent rates. Also, greater hospitalization rates in older adulthood, which is a fastest growing segment of our population. And so in terms of older adults, the incidence rates are highest for diagnosed mild traumatic brain injury among women over 65, and the highest rates of fall-related emergency room visits are among females 65 and over, and Medicare recipients with traumatic brain injury are mostly female in the US, and older adults within home care, within Canada using home care with traumatic brain injury are mostly female. And intimate partner violence affects 1 in 3 women globally, with 92% of hits to the head, face, and neck. So we don't have good incidence or prevalence on this, but the estimate based on more convenient samples suggests the numbers are huge, and especially since most women do not seek care at time of injury. Women also have higher rates of work-related brain injury due to assault. They also have the highest rates of injury in social service and education sectors. And further, there's evidence of higher concussion rates in girls and women's sports with similar rules as male counterparts, such as women's soccer. And there's also been some of the greatest increases among girls and women. And we've seen, for instance, a dramatic increase in concussion in emergency rooms across the age span over a 10-year period in Canada. We saw a 19% increase in males, but an 83% increase in females. And the largest increases are among, a large increase were like among girls, females in sports-related concussions. I just want to see the slide is advancing on its own, so that's why it's flicking up. I noted early in my career that there's a paucity of data on how a brain injury affects a woman's body, specifically like reproductive health outcomes. So with CRHR funding, we conducted a retrospective cohort study on which we published in the Journal of Women's Health, and I wish to recognize our team. And in this study, we examined outcomes related to menstrual cycle, irregularities, fertility, cervical cancer screening, and other health measures such as mental health, energy and fatigue, and overall self-related health. And we identified consecutive cases of brain injury from clinical records of trauma acute care hospitals across Ontario, and contacted women up to 12 years post-injury and conducted face-to-face interviews. And we compared them with controls matched on age, education, geographic location. And what we found was that 68% of women reported that their cycles had become irregular after the injury. 46% experienced amenorrhea from 2 to 60 months after the injury. And there's no significant difference in the ability to conceive that we found between women with traumatic brain injury and those without. But women with traumatic brain injury were more significantly more likely to have postpartum difficulties and fewer live births. And they were less likely to have a pap smear within 3 years, which was borderline significant. Women also with brain injury had significantly lower scores on emotional well-being and energy fatigue compared to women without traumatic brain injury. And we realize in general that women have higher baseline rates of depression and anxiety, which can affect outcomes. When we conducted focus groups of women with traumatic brain injury, women told us, I wish somebody would have told me that menstrual cycle disruption was common after a brain injury. And in response to this, we created a brochure at the Toronto Rehabilitation Institute for patients on this topic. Since our work was conducted, menstrual cycle abnormalities have also been found in milder injuries such as concussion, and also research supporting the menstrual phase, a type of injury, specifically injury during the luteal phase, is associated with worse self-reported quality of life and post-concussion symptoms. Our lab has also conducted very long-term outcome studies of inpatient rehab patients with moderate to severe injury, and we looked at gender differences. We examined self-reported symptoms using a problem checklist and asked former patients on the impact of these. And in a study of persons 24 years post-injury, women reported more headaches, dizziness, increased loss of confidence compared to men, as well as the ability to initiate daily activities, a need for supervision and assistance, as well as a high sex drive as more problematic among women. And in focus groups of women many years post-injury, women did report that these changes in sexuality affected their vulnerability to abuse. A lot of our research has involved analysis of large administrative data from our publicly funded healthcare system, and we utilize data from emergency room visits, hospitalizations, and inpatient rehab across the province of Ontario, and have been funded by the National Institutes of Health for this work. And I wish to recognize our team. One of the comorbidities we decided to study was neck injury comorbidity among concussions identified in the emergency room departments by sex across the lifespan, resulting in this publication. And this was of interest because of the issue of differential neck musculature as a way of understanding the experience of concussions by sex. And in this study, we examined over 90,000 patients with their first concussion identified in the emergency room over a 10-year period. And we examined with patients with a comorbid neck injury at time of this concussion visit. We examined the frequency of comorbid neck injury and its relationship with social demographic and injury variables. And we looked at mechanisms of injury as well. So with respect to our findings, we found significantly higher rates of neck injury comorbidity among females in the population study, but interestingly, it was not consistent across age. It's significantly higher for females in the age range that coincides with the onset of puberty and menopause. And this was found across mechanisms of injury. And as such, there was a non-linear effect with age, just showing the complexity of this kind of research and how an intersectional perspective is important. And these findings were actually featured on the NIH website. We've also examined comorbidities by sex in inpatient rehab setting. This includes data across Ontario on every rehab bed in the National Rehabilitation Reporting System, and conditions that we found significantly more prevalent among females were disorders of the musculoskeletal system and mental health conditions, which informs practice. Using a data mining approach, we grouped 2,600 ICD codes of health conditions existing prior to traumatic brain injury. And in our sample of almost 26,000 patients, we found a greater numbers and types of comorbidity associated with functional outcomes that they differed by sex. We have benefited from a sex and gender approach in research as the world looks to science to address COVID-19. For instance, the pandemic has also resulted in increased reports of intimate partner violence, which differentially impacts women, and it's been called the shadow pandemic. And we also know that women with traumatic brain injury report vulnerability to abuse. And overall, they have repetitive injuries where care is mostly not sought a type of injury. Our research, funded by CIHR and Women's College Hospital in collaboration with our amazing partners such as Women at the Center and the Disabled Women's Network of Canada, focused on surveying frontline providers that serve women affected by violence. And this research identified limited knowledge about brain injury among frontline providers and how one would address a brain injury. However, most agencies surveyed said it was possible for their agency to adapt their client services for the brain injured women to take part. And to address this need, we held what we believe to be the first workshop bringing the world of brain injury and intimate partner violence together in Canada, creating a plan going forward with some outstanding community partners. And a major recommendation was the need for traumatic brain injury education, research, and practice. And this was published in this article. With extensive stakeholder consultation and seminal funding from the Federal Department of Justice, we also co-developed an online toolkit to provide information for service providers to address the identified knowledge gap. And the website for this toolkit is abitoolkit.ca, the Abused and Brain Injured Toolkit. And I wish to recognize Lynn Hogg, a doctoral student in our lab with a background in social work, who has taken a lead on this internationally. And although the toolkit was developed for the Canadian context with very specific Canadian resources, it's now being accessed across the globe. And with funding from the Ontario No Trauma Foundation, we are co-creating resources relevant to employment for this population. We are currently conducting a CIHR-funded randomized trial to assess the impact of sex and gender considerations on traumatic brain injury patients and caregivers and clinicians' attitudes and behaviors. And this study, this is the protocol, has been published. And we are in the process of recruiting. So I might ask that we send out a poster maybe to all the participants to see if they would like to report, because we really don't know, what is the impact of sex and gender considerations when you integrate in care? Yes, there are differences, but what happens when you integrate them? Usually include in my presentation a slide about our ACRM, American Congress Rehabilitation Medicine Girls and Women with Acquired Brain Injury Task Force, which has been meeting monthly for about 10 years. And if anyone's interested in participating in the task force, please contact us. We have a very dynamic group of people. And I guess I wish to end by sincerely thanking the Women's Brain Health Research Cluster for the invitation, and also thank the audience for your attention. Feel free to review our lab website. So it's www.abiresearch.ca, and I also included my contact information. And finally, wish to thank all who've contributed to our research program, especially persons with lived experience who've mentored us over the years.
Well, thank you very much, Angela. These virtual talks are always a little bit difficult because you can't hear people clapping, so feel free to add an emoji or if you feel like it. I forgot to mention that we'd have answers at the end of each of the talks, a Q&A session at the end of each of the talks, and then hopefully we'll have time for another very short one. I think you just have to stop sharing your screen. It should be at the top there, Angela. I have a question for you, but I don't like to go first if I see any in the chat, but I don't see anything yet. Yeah, we're also a small enough group that if you feel like it, you can always unmute to yourself and ask a question. But I'm going to take chair prerogative then and just ask a question, which is the menstrual cycle irregularities, and I saw Stephanie tweeting about it as well. Really interesting, right? 68%. That's quite high numbers. So I'm wondering, has anybody looked at sex hormones and levels. I know, I know across menstrual cycle can be a little difficult, but are there any changes? I'm thinking of the work of Don Stein and progesterone.
Yeah.
Has anybody looked at
Well,
it?
our work was mostly self-report, but there have been people, researchers that have taken steps, like for instance, you know, getting serum samples and assessing where people are in the menstrual cycle with the serum samples.
Mhm.
So there's been, the progesterone hypothesis with withdrawal hypothesis. I don't know if you're familiar with that, but
Yeah.
the fact that when progesterone is, highest, and if you get injured there, then you don't benefit from that, the protective effect of progesterone. So anyway, so that's research that's out there. I guess one of the questions that came up with that research is if you're injured in the luteal phase and you're assessed 1 month later, you're
Right.
still in the luteal phase, and
Right.
that's the time when you're not feeling that great anyway.
Right.
So,
Yeah.
so we really have to control for menstrual phase of maybe when you're being assessed, and maybe in addition to menstrual phase of when you are getting the injury. I also want to say that, with the concussion, one of the things the other thing is that some of the menstrual phase work or menstrual cycle work has looked at trauma controls, orthopedic trauma controls and concussion. So I think it was close to a quarter of a sample might have had menstrual cycles, regularities for concussion, but much, much less for orthopedic controls, because you always wonder what's going on here. Is it the brain or is it the trauma? So it's important to have, I think, a set of controls to really get at what's going on. But certainly, I think the next phase, it's just really hard to get serum samples, having looked at it
Sure.
myself.
Yeah. And the
It's
timing and
with a huge number of people and timing of day and people
yeah.
with disabilities,
Sure.
putting that in.
What about postpartum? So I'm thinking, if because the postpartum period quite hypogonadal. So is there any evidence that there's more severe? And again, I understand that injuries differ, but more severe TBI outcomes in the postpartum period compared to outside of the postpartum? Do you know if anybody's looked at that?
That's a very good question. That would be a great researchable question. I actually, it's interesting, we've done this work and we've been approached by Women's College Hospital to collaborate on more postpartum issues, because
Right.
asking the question,
Right.
we're finding, there's a lot of people with a history of brain injury among in our postpartum clinic.
Right. Yeah. You mentioned.
Yeah, and so we actually have a CIHR funded grant, like leads are at Women's College Hospital. We have a CIHR funded grant to look at sort of what happens before and after pregnancy in terms of looking at the population level, in terms of kind of the health service use, but also what people are coming in for. But anyway, there's huge amount of research that could be done around this reproductive health research outcomes.
Yeah, and I'm also thinking, mindful that we only have 1 minute left, but that there is some evidence, including some work we do in animal models in my own lab, but that reproductive experience, so previous pregnancy, can impact brain plasticity. And there's a paper I was just looking at this morning in stroke. And so I'm wondering if there's any evidence in with TBI outcomes too, postmenopausal, because I think they tend to do worse in terms of reproductive experience. So whether previous parity, whether that might influence, but it sounds like that.
Yeah, there has been the postmenopausal. There's been some work on hormones on that, but very little. We have a pilot study looking at kind of, we hope to be published soon, looking at the interface between menopause, postmenopausal systems and brain injury symptoms. There's a lot of overlap in those kind of those conditions. In terms of the things that stand out, or well, anyway, this paper's not published, so
Yeah, no, that's fine.
Students the lead in the afternoon. I really want her to be presenting this.
No problem. We'll ask her to come and speak then.
Yeah, that's a good, I think that would be
Good
great.
segue. Well, thank you so much. Could you pronounce your last name for me so I don't get it
Okay,
wrong?
you have to remember Antonio.
Antonio,
Calling
Colantonio.
Antonio.
Colantonio. It's so easy when you put it that way. Colantonio. Thank you very much, Dr. Colantonio.
It's been a pleasure, and I look forward to the remaining talks. I just do want to say I didn't talk about the early life experiences because I know we're having a great presentation on that in our session.
Yes, thank you. So now, next up, we have a duo speaking, and they can feel free to share their screen while I read out their lengthy bios. I'll try and don't forget to unmute yourself when you're ready to talk. We have Karen Mason and Paul Van Donkler, and it's really a treat to have this duo speaking together. Karen is a co-founder and director of community practice for SOAR, which they'll tell you what it stands for: supporting survivors of abuse and brain injury through research. I can see that at the bottom of the slide. Kelowna Women's Shelter provides emergency and transitional housing, supported second stage housing, counseling support, advocacy, and prevention education to women with children who have experienced gender-based violence. She's a seasoned nonprofit leader and advocate, and also the executive director for Third Space Life Charity, which supports mental health and wellness in young adults. Dr. Paul Van Donkler is a co-founder and principal investigator for SOAR, and a professor at the University of British Columbia's Okanagan campus. I won't say it's the better campus, but it probably is the better campus. His research focuses on the basic mechanisms of sensory motor control and cerebrovascular, neurocognitive, and sensory motor aspects of brain dysfunction resulting from TBI. Since 2016, he's been working to understand brain dysfunction in women. So it's a convert. We have a convert who have experienced intimate partner violence, related brain injury in collaboration with the Kelowna Women's Shelter throughout SOAR. And the fun fact, they combined their fun facts together. Karen and Paul met almost 6 years ago when they both swiped right on the dating app Tinder. Life together and SOAR initiative are the result, and we are the better for it. So thank you very much, and join me in welcoming Paul and Karen.
Thank you so much, Lisa, for the kind introduction, and it's a pleasure to be here. First, I want to acknowledge that we're on the ancestral and unceded territory of the Syilx First Nation here in the Okanagan Valley, and the University of British Columbia, Okanagan, we jokingly refer to as the main campus. So, anyway, we want to talk today about a topic that Angela touched on a little bit in her talk, specifically looking at the intersection of brain injury and intimate partner violence.
So we want to start with some basic did you know statistics. A couple of these I think Angela already mentioned in her talk, but 1 in 3 women will experience violence at the hands of a partner in her lifetime around the globe. In Canada, every 2.5 days, a woman or girl is killed violently, usually by a male family member or intimate partner. And every single night in Canada, 6,000 and more women and children spend the night in shelters because they are fleeing intimate partner violence.
So most physical intimate partner violence involves blows to the face, head, and neck, or strangulation, which makes it a lot different as an experience than brain injury from other mechanisms like car accidents and falls. And I think, as Angela mentioned, up to 92% of survivors of intimate partner violence will likely have also suffered a brain injury as a result of these impacts or strangulation.
But what do we hear about still, mostly, a lot of the time? Sports concussion.
So sports concussion, you know, absolutely is an ongoing challenge. Certainly, you know, I think as parents with kids who play sports, we want them to be able to participate as safely as possible. And certainly collision sports like football and hockey have come a long way in the last 20 or so years around trying to improve the conditions under which their players participate so that the risk of brain injury is minimized. But at the end of the day, it still happens. And so we hear a lot about it in the media. There's a lot of amazing research to try and better understand it and make these sports as safe as possible.
But here's the thing. The Centers for Disease Control in the United States found that 2.3% of women in the US will experience a particularly severe incident of intimate partner violence every year. So if you take that percentage and move it into Canada, that means 230,000 women a year in Canada will experience a severe incident of intimate partner violence. Take that 92% that was referenced earlier, and that suggests more than 212,000 women are probably experiencing a brain injury from intimate partner violence every single year.
And if you compare that to hockey, if you look at the National Hockey League, the exact numbers of players who get a concussion every year tend to be quite variable. A recent paper, or I guess a not so recent paper from about 5 or 6 years ago, came to the conclusion that on average, there was about 38 players per year that got a concussion. So if you look at that ratio, it turns out that for basically every one NHL player that gets a concussion, about 5,500 or more Canadian women will suffer the same injury. So it's a huge disparity, at least when you do that type of comparison in terms of the numbers of people. And it's as a result, it's a huge public health issue.
So in intimate partner violence, obviously there's a variety of ways that a woman could suffer a brain injury. There's a list here. We've heard these from many of the participants with whom we work on the SOAR project. I really wanted to focus a little bit on strangulation. It is the biggest red flag for future fatality in intimate partner violence. It happens in nearly half of cases, and it can lead to brain injury. It can lead to stroke as much as a year after an incident. So it's a really big issue that has not been given the amount of attention it requires, but it's clearly important and needs to be considered when we're talking about brain injury, not just with a concussive blow. This is just a list of some of the ways that a brain injury might manifest in a survivor of intimate partner violence. Angela gave a really good list of the sorts of implications a brain injury can have on somebody. If you're staying in a women's shelter and you aren't listening and you're distracted and you don't show up for your counseling appointments and you forget to empty the dishwasher, which is your chore at the shelter that week, if you get angry at your children, other people's children, the staff, other residents, have issues adapting to life in a shelter, this doesn't come across very well. And up until very recently, most women's shelters and other organizations working directly with women didn't necessarily understand the intersection of brain injury and intimate partner violence, so weren't necessarily trained to give the kind of support these women might need. They might just come across as oppositional and difficult, and then they don't get services that they actually need.
So we started the SOAR Project about 5 years ago now. As Lisa mentioned, it stands for Supporting Survivors of Abuse and Brain Injury Through Research. It's very much a community-engaged, multidisciplinary research initiative, and it's a partnership between UBC Okanagan and the Kelowna Women's Shelter. And the data collection for it began about 4 years ago. It's got three main goals that we characterize as explore for the first one, which is to actually look at the incidence and effects of brain injury and intimate partner violence. This is the main work that's done from a lab-based assessment approach. Then educate, so the idea here is to increase knowledge and awareness of brain injury in those who work with survivors. So again, kind of similar to some of the things that Angela talked about. And then finally, empower, which is to create better awareness and support services to actually have an impact on the outcomes in survivors by taking brain injury into account in terms of some of the supports that are provided.
So the first phase of the explore portion of SOAR is really, as Paul said, about characterizing how often this happens and what the implications are for survivors. So the first piece we do is a series of psychosocial assessments that measure for PTSD, anxiety, depression, trauma history, substance abuse history, and then the brain injury severity assessment, which Paul will describe in more detail.
Yeah, so the Brain Injury Severity Assessment, or the BISA, is a series of questions related to the incidents with the partner resulting in brain injury-like symptoms, like seeing stars or having a headache or having difficulty concentrating after an episode. And if a participant answers yes to any of these questions, then there's a series of follow-up questions about how frequently this happened, when was the first time it happened, when was the last time, how long did the symptoms last. In addition, there are questions about the severity that get into details around any loss of consciousness or post-traumatic amnesia. And then from the answers to those questions, you end up with a score from 0 to 8, where 0 means that you experienced intimate partner violence, but it didn't include physical violence directed at the head, face, or neck, or strangulation. So if it was physical violence, it may have been directed at some other part of the body, or potentially it was other forms of intimate partner violence like psychological or emotional abuse. An 8, on the other hand, is, as you might imagine, the much more extreme version where it happened very frequently. It happened over a long period of time, potentially months or years. Potentially one or more times you lost consciousness or had a period of post-traumatic amnesia. And so the beauty of the brain injury severity assessment tool is that you get this kind of stratification, or what I like to think of as brain injury load. So it differentiates between those that have more exposure or less exposure. And so after we do all those tests of psychosocial tests and the visa, we then bring them up to my lab where we do a number of different assessments, which are things that my lab has been doing for a while now in the context of sport-related concussion. So the nice thing about that is that we have this basis of comparison in terms of how their responses on some of these measures might compare to a young athlete who's just suffered an acute sport-related concussion. So in particular, we do some measures of cerebrovascular physiology. We take a blood draw to look at some blood biomarkers associated with brain injury. And then we do some assessments of cognitive sensory motor function, which I'll show a short video of here. This is on a device called a KinArm, where you're holding 2 robotic manipulanda. And in this particular task, you're asked to hit a couple target objects and avoid all the other objects that come descending from the top of the screen. So in this example, you're meant to hit the vertical rectangles and the circles and avoid everything else. And so I'll just show that for you here. And you can see that people are pretty good in this example, but every so often you make mistakes, especially as the targets start to descend with higher speed. And so then you can measure things like their accuracy and how many errors they made in their attempts to do this. In the interest of time, we're not going to show too much of the data. I'll give a bit of a summary at the end. But we will show some initial, I guess, kind of distributions of the visa score itself. And so what we're showing here is just that distribution from the visa score from 0 to 8, and then broken down depending upon whether strangulation occurred or not. So strangulation is in the white and no strangulation is in the black. And so you can see there's a fairly normal distribution, but there is a tendency for the visa scores to be higher if strangulation was part of the experience. And so we've quantified this over here by categorizing either 0 strangulations, 1 to 3 or 4 plus. And you can see that the visa score gets progressively higher the more you're exposed to strangulation. So as Karen mentioned earlier, the experience of strangulation is one which is associated with the more extreme version of intimate partner violence and likely is leading to more brain injury-like effects. Just some notes on the characteristics of this distribution. So remember, our 0 score means that the participant experienced intimate partner violence, but it wasn't directed at the head, face, or neck, or they had another form of intimate partner violence, for example, emotional or psychological. Only 4 of our 62 participants or 66 participants had a score of 0. So most, 92%, exactly like the data that we presented at the beginning, had experienced a brain injury-like symptom as a result of their episodes of intimate partner violence. Another thing that isn't captured directly in this figure is with respect to Indigenous women. So our participants were recruited almost exclusively from the Kelowna Women's Shelter, and 20% of the participants that ended up taking part in the study were Indigenous, whereas in the Okanagan region, only 7% of the general population is Indigenous. So an overrepresentation of Indigenous women relative to non-Indigenous women. So I'm not going to show you the graphs again in the interest of time, but I will describe a little bit about some of the other things that we found. So just mentioned that the majority of the participants had experienced IPV-related brain injury, and that one of the things we were able to do is, like I said, compare the data that we saw in the survivors of intimate partner violence with some of the information that we've collected previously in acute sport-related concussion. And one of the things that we found is that the symptoms were greater and the symptom severity was greater in the survivors of intimate partner violence than in young, mainly male athletes from hockey and football who had suffered an acute sport-related concussion. And the amazing thing here is that for the athletes, we brought them in within 3 days of their injury. So it truly was an acute time frame. Whereas in our IPV participants, I think the earliest we saw someone was 3 months after their most recent episode. And on average, it was about a year after their most recent episodes. So definitely more chronic in nature, these symptoms that they're exhibiting. From the cerebrovascular experiments, what we found was data that was consistent with arterial stiffening related to the extent of the IPV-related brain injury as assessed with the BISA score. And arterial stiffening has been associated with a number of different longer-term neurodegenerative effects, so that is a cause for concern from a cerebrovascular perspective. The kin arm task that I showed with the movements to hit the targets and avoid the non-targets, the main finding we found was that there was a reduced ability to make fast coordinated movements as that BISA score increased. So people that had higher BISA scores tended to move more slowly in this complex cognitive sensory motor task. So kind of the bottom line is that most of the participants had repeated exposure to IPV-related brain injuries over the course of months or years. This led to chronic symptoms and long-term consequences, both behaviorally, physiologically, and potentially from a neurodegenerative point of view.
So this project, when we first started working on it, was really initially about, let's try to find out the incidence and the effects on women. Once we know that, we thought, well, what's the point of knowing that if we don't do something about it? So that's where the phase 2 educate piece comes in. We started this really by surveying frontline workers. As Angela mentioned, she and her team did as well. We surveyed 150 frontline shelter workers from across Canada to find out what they knew about brain injury and intimate partner violence, what they wanted to know, and how they wanted to learn about it. We found out that they didn't know very much, but they wanted to learn. We also found out that their time was limited, given how pressing tasks can be and the environment can be in a women's shelter. So that led to us developing a module of the concussion awareness training tool for women's support workers. And it's done in partnership with the BC Injury Research and Prevention Unit. The concussion awareness training tool is already an existing product where you can go there if you're a coach or a player or a parent or working in a workplace, and you can take a specific course on that topic to learn about signs and symptoms of brain injury and how to support somebody. So it's a 30 to 40 minute online course. It's video-based and audio-based. It's available in English and French, which is wonderful for our French-speaking compatriots in Quebec and other parts of the world. And the best part, it's free. One thing we love about this as well is that we feel like it's a great complement to the ABI toolkit that Angela and her team developed, which is an incredibly robust and deep resource, everything you ever wanted to know about brain injury and intimate partner violence. So you can take this quick 30-minute course, the concussion awareness training tool, and then we have links to the ABI toolkit on the training tool, and you can go and learn everything else you need to know. And this is what it looks like, and you would just click the women's support worker icon to take the course. And you might notice if you take the course that it's my voice. So if after today you're sick of my voice, give yourself a couple days before you take the concussion awareness training tool. But we did develop it mainly for frontline workers, but it became clear as we were producing it that it could have a much broader audience. So I think anyone who works with women could take it and benefit from it, we hope.
The third phase that we mentioned is this Empower phase that incorporates what we're calling a community support network. So in this particular phase of the project, what we want to do is, or what we are doing is partnering with a community brain injury support agency, as well as our regional healthcare authority. We're implementing a multifaceted intervention that incorporates aerobic exercise, mindfulness, meditation, occupational therapy, and cognitive exercises. One of the first things we want to do around this is take a qualitative approach to identify gaps and barriers, both in terms of the patients or participants themselves, as well as the system, whether it's the healthcare system or community-based supports. And hopefully also be able to do a patient journey mapping exercise in different contexts where there either are some supports in place or nothing existing yet. And then one of the things that we want to get out of the intervention is to survey participants about changes in their quality of life, resilience, and neurocognitive function. So that's a project that is just getting off the ground, and hopefully in a year or 3, we'll have some really clear data that provides some insight into this.
And it's not too late to register for a conference that is in fact happening tomorrow and the next day, based here in Kelowna, but it's online. So anyone can attend. The link to register is there. It is free except for a $10 registration fee. A lot of wonderful experts, including Angela Colantonio, will be speaking. And we've got topics looking at everything from promising practices in rehabilitation that are being tried in various locations in Canada and the United States, to the ethics and legal considerations of screening for brain injury and intimate partner violence. And we also have an incredible author and speaker, Rachel Louise Snyder, who wrote a book called No Visible Bruises: What We Don't Know About Domestic Violence is Killing Us. She is one of our keynotes, and Dr. Eve Valera from Harvard Medical School, who in fact developed the brain injury severity assessment tool that we've been using, and who, as you probably saw in some of Angela's slides, has worked very closely as well with Angela's team on some research. So please register now.
So thanks again, and thanks to our funders who've provided support that allowed us to do this work. Thanks to our amazing team of trainees who do all the work. Thanks for listening, and happy to answer any questions you might have.
Well, again, thank you very much, and feel free to use your emojis, or you can even, I hesitate to say this, but you could unmute yourself and even clap into the microphone, but who knows what that might sound like. So thank you very much, Karen Paul. That was a fantastic talk, and I'm always so, what's the right word? Astonished at the ratio of interpartner violence, TBI, to sports-related injury, TBI, at least professional sports related. And of course, there's so much more attention paid to the NHL. And so, I mean, this is a very probably bad question using chair's prerogative, but because you said something about 38 NHL players a year. Is that only in Canada, or 38 across the league? And is that ratio about the same between NHL and NFL? And the reason I'm asking this is the percentage just so much lower in professional sports compared to interpartner violence? And so how do we get that message out to the general public, right? Like, this is what we need to pay attention to.
It's a great question. I mean, it is hard. Most of the studies that looked at brain injury in sport-related concussion don't really look at number of players per year. It's more number of injuries per hour of activity, or that sort of thing. So it's basically, you know, what is your expectation of getting injured based on how much exposure you have.
Right.
So the 38 number is not always going to be accurate, right? Certainly, though, it's for all of the NHL, North America. I don't know. I should know this. The difference between NHL and NFL in terms of concussion rates. I don't know. Will, do you know that answer?
I'm also wondering if there's underreporting, right? I know the NFL. I saw that movie with Will Smith. There was underreporting, right? But there's also underreporting with IPB too. So I don't know. Did you want to? I mean, we'll have a chance at the end too, but
I mean, it's certainly better than it was 20 years ago in terms of contact and collision sports. So, you know, there are protocols that are meant to be followed, and both in terms of, you know, the actual, you know, moments after it happened, and a very quick initial assessment that allows a decision to be made, and then follow-up assessments as they recover. So, you know, sports in general, both at a professional and junior and minor level, the knowledge and awareness of brain injury and sport-related concussion is light years ahead of where it was 15, 20 years ago. And it's still not perfect, right? And
Yeah.
so, yes, people are going to slip through the cracks. People are going to try and not, claim that they've had a concussion and want to get back out there, right? So there are a lot of issues around that. But at the end of the day, it's a lot better than what it was a long time
And
ago.
I will also say that my daughter lives in Kelowna with 4 other 20-year-olds. Nobody needs to know that, except that one of them was skiing on Big White, and his head went to one of the clinics in Kelowna, and they said, you don't have a concussion, even though he'd been throwing up. He was not, like, it was typical concussion injury. So again, underreporting anyway, even from in the clinical field, probably.
I think that Paul would, that calculation is very much what Paul would call a back of the napkin figure, right?
Sure.
We don't pretend that it's 100% evidence-based accurate. The point is to show the catastrophically high numbers of women this is happening to all the time, who they themselves often don't know it's occurred, and certainly the system doesn't know it's occurred and isn't providing the supports.
No, it always strikes me every time, always gives me goosebumps whenever I've heard that. There is a question from the audience, and then unfortunately we have to push on. So if practitioners use a brain assessment tool and determine clients have symptoms indicative of TBI, what are the next steps for survivors? Actually, this was another one of my questions, so thank you, Lori, for asking this question. And are you partnering with organizations in the US? Also, very good question.
Yes, we are.
Yes. So next steps, that's part of the challenge is, and then we alluded to with the empower phase, right, is that the system isn't necessarily set up to be able to provide brain injury informed supports. The experience of women who've experienced intimate partner violence is a very, very complex one. And so quite often the supports that are provided will fall short, or the person will never get to access to those supports. So it's definitely an ongoing problem for this population.
And that's sort of the piece in the educate phase. We're working closely with women's shelters across Canada to ensure that the staff take the concussion awareness training tool, women's support worker module. We've created some initial resources both for survivors and frontline workers to share and give them the basic tools of what they can do in their daily practice to support women who've experienced a brain injury. And we're also encouraging them to become familiar with brain injury support organizations in their communities and with any practitioners and clinicians who could support. So it's a long and slow process. And I think the piece is education and getting those resources out there. And we are working with some groups in the United States because, well, Angela will say this too, there aren't that many people who are working on this area right now. So we're all collaborating a lot and supporting the work each other is doing to get the word out.
Yeah, we're always stronger together. Always bothers me in science when we try to fight each other, it's important to band together. So thank you very much. I'm going to have to move us along, even though this is very fascinating and more questions are coming up. And feel free to put more answers into the chat if you want. It's my pleasure to introduce Dr. Andrea-Anne Ledoux. Let's hope I pronounced that a little bit better. My daughter says my French accent's terrible, but and while I'm presenting, maybe she can share her screen, or introducing her, maybe she can share her screen. Dr. Ledoux is an assistant professor at the University of Ottawa in the Department of Cellular and Molecular Medicine and in Neuroscience. She's also an adjunct professor in the School of Psychology and at Neuroscience at Cullen University. Her research interests you'll hear about, but including novel approaches for assessment, treatment, and understanding of concussion and mental health. Currently, she's investigating concussion and early return to activity, resiliency, and mental health in concussed youth, and that's partly will aid us in our answer to one of the questions recently. And her fun fact is that she has 3 young kids, 6, 6, and 9. And she loves to garden and make pottery. Hopefully she has time to do pottery and gardening with her 3 children at home. So thank you very much, Dr. Ledoux.
All right, thank you, Lisa. All right, hi everyone. I hope everyone is doing well today. Today I will be examining why it's important to consider sex and age when defining recovery in concussion. So my funding and conflict of interest, I'm currently supported by the Innovation Fund of the Alternative Funding Plan for the Academic Health Sciences Centre of Ontario, University of Ottawa Brain and Mind Research Institute, QRI. Mobile Interactive is our industrial partner, and the Ontario Brain Institute. And the project that I'll be discussing today is supported by CIHR. So our learning objectives for today, we will be looking at the biological brain maturation differences across development and sex. And afterwards, we'll look at recovery and recovery trajectories across age and sex again. And afterwards, I'll be introducing a tool that we've created to better rank symptoms in both girls and boys. So there are biopsychosocial differences that exist between the different stages of development between sex and individuals that may influence a concussion. For example, as we can see on the left side of the screen, volumes of cortical gray matter appear to increase during childhood, reaching peak levels around the time of puberty onset, and after which they gradually decline. So here, a higher percentage of gray matter is represented by red and yellow colors. Other important considerations are glucose metabolism and synaptic density, which follows a similar profile where there is an increase and then decrease of glucose and synaptic density, both peaking during adolescence years. Sorry. Another important brain maturation that is worth discussing is white matter. So white matter is composed of axons, and axons ensure smooth communication through the in in two important ways: by conducting electrical impulses and by transporting various molecules and organelles from the cell body all the way to the next neuron, or to the synapse and then to the next neuron. And hence the importance of maturational changes in white matter during the development for the child's cognitive development and mental health. So a side note here is that the exaggeration of typical adolescence maturation processes combined with psychosocial and biological environmental factors can actually cause psychopathologies during childhood and adolescence years. So basically during adolescence year, we see the emergence of certain psychopathologies such as schizophrenia, which is more prominent in males during adolescence years. And then we have as well anxiety disorders, which are more prominent in females. And we also see substance abuse and depression. So volumes of white matter across development show a clear linear increase throughout childhood and adolescence, with the maximum volume reached at the third decade of life, so around 2025. And so it seems that males have relative greater white matter volume, and it's theorized, and this we can actually see here on the right side, and it's theorized that this is due to actually the caliber of the axons that are bigger in males than in females due to levels of testosterone. And so by caliber here, I mean more the caliber of the nerve fiber right here, and this does not include myelination, and it's thought that the caliber would be influenced by the levels of hormones in males. And so why am I discussing all of this and axons and different biological factors? Well, a concussion, when we really look at what is a concussion is associated with axonal injuries due to shearing forces. And it's also associated with cortical neurochemical metabolic cerebral blood flow and mitochondrial dysfunction. And so considering the biological differences and psychosocial differences through development and sex, recovery in concussion should not be defined by a one-size-fits-all approach in the pediatric population. So in concussion, we have these consensus and these new guidelines that come in every 4 years. And so the Berlin consensus statement indicate that there is a need to understand recovery through development in order to better treat patients with a concussion. So rigorous studies of the natural progression of recovery are needed to better understand what is recovery through each developmental stage, but as well through sex, and so what it looks like. And so we decided to investigate recovery through age and sex over time, and to create a tool that can inform clinicians and parents on the recovery status of their child by age group and sex. And so this is a secondary analysis of a prospective study that conducted in Canada called the 5P study. And so a brief overview of the 5P study. This was a multi-center prospective observational cohort study. A total of 9 Canadian pediatric emergency departments were recruiting for this study across Canada. And so our inclusion criteria to be part of this study were to be female or male between the age of 5 and 18 years of age. And these participants or these patients needed to had sustained a concussion within the last 48 hours of their ED visit. So they were really in an acute phase of their concussion. And so the outcome of our study was the proportion of children that have recovered at 1, 2, 4, 8, and 12 weeks. And we were interested at the distribution of recovery by age and sex through time. And so our definition of recovery was having no new symptoms compared to the perceived pre-injury score using an assessment tool that we call the post-concussion symptom inventory. We also looked at symptom change across time to see how this differed between sexes. So the tool that we used, as I just mentioned, was the post-concussion symptom inventory, and this is a validated, reliable scale with excellent internal consistency and inter-rater agreement. And so we used the 3 developmentally specific version for our study. The age group for each versions are 5 to 7, 8 to 12, and 13 to 18, with different items yielding different scores ranges. And so a question, these are just selected questions. There's many more questions on this assessment, but a question could be, have you had a headache? Has your head hurt? And they need to rate it before their injury, and they need to rate it after their injury or in that specific moment. So overall, we had 3,063 participants that were included in this analysis, and we have, so we do have a considerable amount of participants in this study, making it generalizable to the ED population. The rule to be included in each time point was to have at least 85% completeness of the items on the PCSI, and so we did allow for 15% incompleteness. So the results for recovery, overall 64.4% of children have recovered by 12 weeks. When reviewing the proportion of recovery over time separated by age, by 12 weeks, 71% of children between 5 to 7 have recovered versus 70% for youth between 8 to 12. Versus 56.2% for adolescents in the age group of 13 to 18. And so we can clearly see here on these 3 graphs that there is a greater proportions of males that have recovered at each time point compared to females. So males are in blue and females are in red. So it really shows or demonstrates well the differences in recovery after having a concussion. So if we examine the association between recovery or here symptom change and sex and time while adjusting for important covariates that have been associated with longer recovery, such as, for example, previous number of concussion, personal history characteristics. And we adjusted for over 21 variables. And so the curves here are the predicted trajectory of one participant in the 25th quintile and one participant in the 75th quintile in terms of age for each age group. So age group 5 to 7 on the left and the age group 13 to 18 completely on the right. And so there seems to be a main effect of age in the age group 8 to 12 and in the age group 13 to 18. And so basically all that means is that the older you are in both categories, the more symptoms you have, which is represented by the red line that we see on these graphs. But we also note an interaction effect for the older age group, so for the adolescents group. So being older in this category is associated with an initial steeper decline of symptoms. But overall, we didn't deem the age differences as clinically relevant, although it was statistically significant. Now we present the curves that are the predicted trajectory of one female and one male for each age group while adjusting for the 21 variable. And so here we looked at the effects of sex on symptom change after having a concussion. And so we've noted that there is an interaction effect between sex and time for the age group 13 to 18. And so by examining the slope of females on the right side right here graph, there is an initial steeper decline of symptoms when compared to males. However, we can clearly see that that symptoms don't actually resolve completely and they just linger over time. And so it takes longer for females to recover. And so the predicted symptom change for male occurs really in the first 2 weeks after having a concussion, and it will flatten out between weeks 2 and 4. And by 4 weeks, 91.8% of symptoms have actually improved in males. So 92% have improved in males and only 80% in females. And so female symptom change will be plateauing between weeks 4 and 8 compared to males, which I had just said is between 2 and 4 weeks. And so sex differences in recovery are likely multifactorial and might be explained by anthropometric differences, axonal size differences, pubertal hormonal differences, higher rates of injury and symptom reporting, as well as pain perceptual differences that are really different between males and females, and gender conformity, which has really not been assessed or studied a lot in the pediatric field of concussion. So given that age and sex differences given that we saw differences in age and sex, we created a tool that could give a better perspective for the clinician and parents on the symptom ranking of their child compared to the sample population of their age group and sex. And so we achieved this by generating central curves with the recovery score. And so the recovery score is the pre-injury score minus the actual score. So we've created a delta score. And so on the complete left side of your screen, you'll see the 5 to 7 age group. Middle section is 8 to 12. And on the complete right side is the age group 13 to 18. And above, these are all the central curves for males, and below are the central curves for female for each age group. And so if we zoom onto 2 of these graphs, and so this is an example for the curves of the age group 13 to 18. And so if you're a male that has a recovery score of 20 at 4 weeks, so at 4 weeks you have a score of 20, you're actually in the 90th percentile in terms of recovery for that particular time point, meaning that there's 90% of children at that time point that have less symptoms than that particular patient. And in fact, 50% of all males in this age category have actually recovered. And so this is the black line, if you can see it on your screen. And when we compare this to female, if you're a female that has a score of 20 at 4 weeks, you're actually in the 75th percentile for recovery, meaning that there's 75% of the population that has less symptoms than you. And when you look at the 50th percentile, which my mouse is not working well, but 50th percentile at 4 weeks, actually 50% of females have not recovered by that time point. And in fact, if we look at 12 weeks, the line is not touching 0. By 12 weeks, we still have 50% of females that have not recovered after having their concussion. So our key messages for my presentation is that most children between 5 to 12 do recover from a concussion over a 3-month period. However, this is not the case for the age group 13 to 18. We do see sex and age differences, and they exist, and these differences are present over time, and these need to be considered when investigating recovery, or they need to be, at least sex does need to come when a female patient is seeing a clinician. So finally, we did create sex-based and age-based recovery curves, and these can provide a better perspective on symptoms and guidance for clinicians. Thank you. Oh, and this is the entire team that worked on the 5B study. So it was a huge team that recruited for us across Canada. Thank you.
Thank you so much, Dr. Ledoux. I think we have one more presentation, so I think instead of questions, if you can hold them, I'm going to get Dr. Panenka to give his talk, and then we'll do a Q&A with both of you, which is unorthodox, I know, but it was fantastic. And I have a whole bunch of questions for you, so hold on to your hat. Thank you so much. And Will, you might want to swap displays. Oh, and I have to introduce you too, because we can see your presenter view. So Dr. William Panenka, it's my privilege to introduce Dr. Panenka. He's a duly certified psychiatrist and neurologist and associate professor. You're going to figure out very quickly what his fun fact is, with the BC Provincial Neuropsychiatry Program and the Department of Psychiatry at UBC. He is also part of the BC Mental Health and Substance Use Services Institute and the David Mofagan Center for Brain Health. He's a medical lead at the Neuropsychiatry Concussion Clinic and neurology consultant to the Fraser Health Concussion Clinic. His clinical focus is on treating complex neuropsychiatric illness, including TBI, while his research program focuses on mental health, addictions, and traumatic brain injury in multiple populations, ranging from athletes to homelessness. So his fun fact is that he did 24 years of post-secondary education. And he says he took, and my parents had the same advice for me. I didn't quite stay in school as long as he did, but he said, I took my parents' advice to stay in school, maybe a little too literally, maybe. So, Will, we're still seeing that one screen, but at the top, it says swap displays. Does it not work if you just push on that? Not that it matters. We can live with it. We'll just see your notes. Yeah, perfect.
Yeah, okay, good.
Yeah.
Do you hear me okay?
Yes.
Okay, Lisa, thank you so much for letting me speak. It's a really quick presentation, should only be like 9 to 10 minutes long, and it's just to introduce you to a project that we've been working on for the last decade in Vancouver's downtown east side, in an attempt to just get the word out and also to foster collaborations, because I think that one thing that we really want to do going forward is to we have a unique opportunity, I think, to look at sex and gender differences in short and long-term outcomes. So, your feedback and potentially later collaborations. This is Vancouver. So the UN lists this generally as one of the top 5 places in the world to live. Within this beautiful downtown core, however, there is one of Canada's highest concentration of marginalized folks. So this study was started by the ex-head of psychiatry here at UBC. His name is Bill Honer. And as far as we can tell, it's the most granular study of neuropsychiatric health of precariously housed persons worldwide. So CIHR has been funding it since 2010. We started following over 500 folks that were marginally housed back in 2010, and we're still following a little over 350 today. And what's unique is the depth of that follow-up. So every year they get a full assessment by a psychiatrist, they get a full neurological assessment, they get a battery of specialized testing, they get monthly visits for all their clinical symptoms, urine drug screens, detailed day-by-day drug quantification, and also uniquely multiple brain MRIs for every participant. So it's this level of having a trajectory. So not just what happened after a TBI, but what was it like before and after that makes it powerful. This little circle that you have here is Vancouver's downtown east side. This little H is St. Paul's Hospital. What this represents in red and in blue are the number of visits to this hospital for mental health. As you can see, they're not in the majority of downtown. They're coming from this very concentrated area. This is what it looks like for substance use. As you can see, and Vancouver is a very well-populated residential downtown. The substance abuse visits to the local hospital, they don't come from here. They come from here. So this is where our cohort comes from. This is, so about approximately 1/3 are women. And as you can see here, this is what's called a very multi-morbid population. Their health is poor. Substance dependence, 95%. Stimulant use, so cocaine, 80%. Heroin, 40%. Alcohol, 20%. Any mental illness, 3/4. 1/2 have a psychotic illness. And let's just skip down here to HIV is 20 and hepatitis C is 70. Okay, so as you can see, they are suffering from an immense burden of illness, and out of that, substance use is probably the most prominent. Trying to advance the slide. Hang on a second. Okay, there we go. Is the most prominent and probably affects their life on a day-to-day kind of overall. At least our academic concentration is there because it's such a strong factor to their health. So what about TBI and substance use? Well, substance use is a very strong risk factor for traumatic brain injury. The relationship is bidirectional. In our emerge, about 50% of the people who experience a traumatic brain injury are intoxicated when they come in. And that combination of substance use and TBI markedly increases your suicide rates. So this is drawn from a recent review, and it's just a so it's a little synopsis of what is known, which is not much, you know. So a lot of this you have to take, it's just very preliminary data on the interaction between sex, gender, substance, and traumatic brain injury. Females thought to have more rapid progression through the stages of substance abuse. So as an example, alcohol, they start later, but get to dependence quicker. Shorter periods of substance abstinence, both alcohol, cigarettes, and cocaine. I think there's evidence for that also. They're more likely, as you've heard, to have poor outcomes, especially after mild traumatic brain injury. Intimate partner violence, so mechanisms are different. And post-injury, there is some data showing a vulnerability of a TBI in younger ages, especially in adolescence, and its influence later on whether or not there's a substance abuse issue. Men are more violent, more likely to binge drink, more likely to get severe traumatic brain injury, more likely to be injured in young adulthood, that's sports, fights, and they're more likely to, some evidence indicates they're more likely to return to high levels of drinking post-TBI. So substance use and traumatic brain injury intersect in a very negative way. In athletes who have very healthy brains, much healthier than mine, a concussion can set them back years. So the reason why we're looking at this is what happens in a population with very little reserve. And so we think that it may represent an underreported, frequent, and disproportionately functionally impairing event in this population. Okay, so here's the study design. So they are followed again for years. When they experience a traumatic brain injury, we pull them into a different stream. They're given 2 brain MRIs, and they're followed very, very closely for that whole year with a bunch of assessments, both physical and psychological. And then at the end of the year, they're put back on the regular stream. Okay, here's some data from the MRI. Green represents people who have parts of their brain missing from traumatic brain injury. Yellow, more than one participant with parts of their brains missing. Many of these people report only a history of mild traumatic brain injury. Some report no traumatic brain injury. Okay, and as you can see from this picture, this is why TBI is considered a silent illness. In the front here, this is personality. You know, here in the temporal lobes, this is memory. So these are not areas that cause you to, you know, be paraplegic or cause you to blindness or other disturbances that are really obvious. Okay, this is personality and memory. So what are we finding? We were talking about the athletic population and incidence being very high. So in this preliminary data shows that that in this population, it's up to 30% per year. That's way higher than athletes or military. 4% moderate and severe, again, dramatically higher than the rest of the population. And interesting, so sex right now is not a risk factor. So it seems like women are equally vulnerable to men in this longitudinal study for experiencing mild traumatic brain injury. As far as the risk factors, alcohol and opiates, and interestingly, schizophrenia is one of the protective factors. And I bring this up because of the stigma associated with schizophrenia. People often think it's unpredictable and violent. Well, it looks like actually in our population, they're more scared, you know, than violent. So what are the consequences of this? This is just an MRI showing changes after mild traumatic brain injury, but we're not finding that one concussion, we can't pick it up, probably because of all the other issues going on with the substance use and whatnot, overwhelming our signal. But multiple concussions, we do pick up a difference on the MRIs and cognition. So this is not surprising, but alarming, and echoes what's been said by a number of people today, is that violence is a disproportionate contributor in this population. And in women, more than half of their traumatic brain injuries are due to assault. More than half the TBIs in the population as a whole are assault, but in women, half the assaults are related to an intimate partner or date, right? So that's striking. Okay, you know, that's almost it. This is my my grad student just reiterating what I've just said, because the easiest way to get people to remember, I find, is to tell a story and then retell it at the end.
New research out shows an alarming correlation between being homeless and suffering from a traumatic brain injury or TBI, with those living without accommodation over 50% more likely to have received one.
So what we found was that 1 in 2, approximately, persons who are homeless and marginally housed has had TBI in their lifetime. And perhaps more strikingly is that about 1 in 4 has had a moderate or severe traumatic brain injury, or TBI.
The UBC-led research analysed various different case studies of head injuries in 6 different countries, including Canada, dating back over 20 years. The results show homeless individuals are 10 times more likely to suffer a TBI than the general population, with violence often being the main factor involved.
In the general population, it's often falls or motor vehicle accidents or sports. And in this population, across all studies that have looked at mechanism of injury, it's assault. And so oftentimes in women, it's assault through intimate partner violence.
It's a sad statistic that for those working on the front line of Vancouver's over 2,000 homeless population know all too well.
It's very common for our staff, even a few times a week, to see people come in from our community that are suffering with a brain injury. Having a brain injury for our guests is a massive challenge, and they don't have a lot of the supports that they need, people that can support them through that process and the ways that it negatively impacts their life.
Researchers at the moment say it's unclear if you're more likely to receive a TBI if you're homeless or if it's the other way around. New research out shows.
Okay. Thanks. So just the last slide, kind of significance of it all. I think, the advocacy and stigma here is so important. It's naturally a difficult population to care for, and I think it just makes a difference knowing that the traumatic brain injury, which could happen to you or me or our kids, might be playing a part in why sometimes they present as difficult. Education, so we've got an educational program now set up, a knowledge translation initiative, informing public health resources, and hopefully facilitating access to appropriate housing and treatment, all so that we can hopefully lessen what has been found to be related to traumatic brain injury in this population, which is more suicide, incarceration, depression, psychosis, poor mental health, homelessness, and long-term cognitive issues. Thank you so much, Lisa, for giving me that 10 minutes today.
Well, thank you. Thank you to both Dr. Panenka and Dr. Ledoux for that. Just so you are all aware, and Will, you can stop sharing your screen if you want. Although that's a very tranquil scene after those very powerful contributions, which is nice to have. I was just going to say that one difficulty I do have with the cluster is coming up with people that identify as men, either as members of the cluster or as speakers. So when I asked Will to speak, he said, actually, I think you should get Dr. André-Anne Ledoux to speak. And so, I got 2 for the price of 1, which was fantastic. So remember, you can either unmute yourself and ask a question or but I'll ask Dr. Ledoux a question first. So I really like the trajectory of recovery with age, because that is certainly, whenever one of my kids actually it's just my son, if I'm doing a little sex analysis in my own household that has had a concussion. But I think it's very helpful for people to sort of see where they might fall in a recovery. In your sample of 13 to 18, even though it's a short, it's 5 years, in terms of sort of the maturation of the being, I don't know how you put that, but a 13-year-old very different than an 18-year-old in my mind. Maybe not so much puberty-wise. I'm sure that was probably part of the impetus of splitting it that way, sort of pre-puberty, post-puberty, and in the middle. You're muted in case you're trying to answer my non-question. But I'm wondering if that plays a role, if you see bigger differences in the 18, or maybe there's not enough of a sample size to see that, or if you see any kind of pubertal involvement.
So puberty was not part of the 5P study, which is quite unfortunate. And for our next studies, we are including puberty scales. So why we chose 13 to 18, this was really principally based on the outcome measure that measures, so the outcome measure was made for 13 to 18-year-olds and for 8 to 12. So we had different measures used for the different age groups. And so this is why we decided to go on these cutoffs of 13 to 18. And I do agree, a 13-year-old is quite different than an 18-year-old in terms of maturation. And to separate it even more, I think we would start having a bit less power to be able to analyze it. We did do another study where I did actually separate it by age group, and this was just to look at pre-injury factors separated by age and sex as well. And across the board, it looks pretty similar in terms of trajectory. We do have a bit of differences, but all that to say that 13-year-olds are quite similar in terms of recovery trajectories than the 18-year-olds.
Interesting. Has anybody done, there's two questions in the chat, and I do apologize. We'll go about 5 minutes over today, just because in the interest of getting all that questions in there. But you know, it is recorded, so if you have to leave, you'll be able to watch the recording afterwards. By the way, even though we have something like 30 people on, there are over 100 people that are registered, so it's very possible that you'll get questions afterwards. But okay, let's ask a question from the chat instead of my question. What is spontaneous recovery? Or, and this is from Gabby Polowski, or were some children getting concussion treatment?
So all patients here went through the ED, and so they received usual care. And back the study was done in 2013 to 2015, and so back then those were the old guidelines, which were to rest until asymptomatic and then start back your activity routines or start back physical activity. So those were the treatment given. It is possible that some patients, this was an observational trial, so it was not an RCT, so it is quite possible that some patients went to see their physiotherapist to get some help. That is quite possible in this study.
Thank you. Will, I think we'll ask your question from the chat here if you've seen it already. I don't know if you've seen it, but it's from Chloe Powell. For the MRI results, how do you control to determine what the brain changes can be accounted for by TBI versus mental health difficulties? So obviously cognitive effects of like psychotic spectrum disorders, schizophrenia, depression, they all come with some changes to brain or problematic substance use.
Yeah. So good question, and that's why the design of the study is longitudinal and pre-post. So the MRI that I showed you, which kind of spun, those are large areas of brain that have what's called encephalomalacia. So actually areas that are missing. And that can really only be caused by things like stroke and traumatic brain injury. And for that, you get a neuroradiologist to go over it. And there's certain areas that are more likely to be traumatic. So that's that. As far as the other one goes, the more the DTI findings, the reason why you can attribute that to traumatic brain injury is because this is the same person who's had, say, a psychotic illness for the past 5 years. And then you've got, say, two baseline MRIs, and you show what the change has been over that year with, say, that psychotic illness. Then they have a traumatic brain injury, and you do the MRI 2 months later, right? And so because you've got that pre-injury brain trajectory, you can attribute what that scan looks like 6 weeks after the TBI to that traumatic brain injury.
And so I think I'm going to just, even because we have like 2 minutes left, well, not really, we have -3 minutes left. But I was going to open it up to everyone. I think Dr. Andréane probably answered this pretty well already, but do you see age effects in any of your work? And of course, when I'm thinking about women and women's health, I'm thinking premenopausal versus postmenopausal. So for intermittent partner violence, I think I sort of asked Dr. Cullen about this already, maybe a little bit, but I'm also wondering in terms of homelessness, or if any of you want to answer that in terms of sort of post 50, maybe post 55 kind of, do you see any differences and in terms of recovery or symptoms?
Oops.
Anybody?
Sorry, Lisa, I was just answering a message via the chat.
Yeah, no problem. No, I'm answering the message via chat. Yeah.
So it was over 55 was the.
Yeah, I'm just wondering postmenopause. I have heard, you know, a tale, and it might just be one of those. I hate the term old wives' tale, but I can't think of any other old wives' tale of that the recovery from traumatic brain injury or concussion is much worse postmenopausal than premenopausal. I'm wondering if there's any evidence to back that up, and or if you in your own research, if you've looked at sort of age-related differences in symptoms or anything.
So clinically, I see a lot of brain injury, a lot of concussion, and you know, age definitely. So the more morbidity that you have, but specifically due to the hormonal changes, that I'm not sure.
Not sure.
No.
And
we did do a study on over 700,000 persons with brain injury and follow them over time to look at dementia risk. And we did find that women developed it earlier. You know, I think age was a factor as well in terms of that. And if they had a spinal cord injury, that also contributed to dementia risk. So, I mean, traumatic brain injury is a risk factor for Alzheimer's. I think the Lancet has now confirmed that it is a risk factor. So,
yeah, no, it is, but it would be really. It sounds like there's a possibility that it might be a greater risk factor for women compared to men. The difficulty there is that, well, Alzheimer's disease, at least there's a greater lifetime risk for women anyway. So you'd have to sort of try and tease that apart. But that would be really interesting if there was a greater risk for women with TBI.
Well, I think it's interesting, like there's biological sex and then gender influences. So, I think I've seen some reports that the risk is like between the two is kind of narrowing down because it could be that women were less educated before. And so the effect of education, you know, more return to work, more occupation may be attenuating some of those differences.
Yeah, I mean, that's part of the stuff I study. So yeah, there's some controversy in the field. That's why I was very careful to say lifetime risk, because you can get into trouble. And it also depends on right now, European versus American, which is also populations. When people look at it, you don't see much of a sex difference in American populations. You do in Europe more so. But even if you don't even think about that in terms of cognitive decline, even if you don't think about risk per se, but just cognitive decline is much worse in women with Alzheimer's disease than in men with Alzheimer's disease. So that is also that would be interesting to look at too, just symptoms of dementia and in relation to TBI. That could be something to look for. All right, well, go ahead. Sorry, if anybody wanted to say anything. I hate cutting people off. It's the worst part of this job, I have to say. Chairing is cutting people off, because those are really fantastic presentations. I wish we had more time. When we first decided to go online, I wanted to make them short and sweet so people weren't online for a whole day because we're already zoomed. That was before we were zoomed out. Now we're really zoomed out. But I think this is going to stimulate more conversations. I hope it does. I hope it stimulates some sex and gender work for you, Will. Always happy to help you, even from the sidelines, because you have some other experts here that are much more attuned than I am. So thank you. I just want to collectively thank you all for giving fantastic presentations, and hope to hear more from you in the future. So thank you so much. Thank you for your little emojicon thingies. And for keeping on time. That was pretty amazing to have, 5 of us all in a 1.5 hour time period. We did pretty well, I'd say. You guys did pretty well. So thank you so much for your work.
Thanks, Lisa.
Thanks, Lisa.
Bye.
Bye.
Bye.